Good afternoon. A warm welcome to all of you. Let us start the afternoon session. To chair the session, we have chairpersons Dr. Virendra Sharma, Anjali Bure, Dr. Prabhakaran Pillai, Dr. Arvind Rai, Dr. Nandita Mehta. So, welcome to all the chairpersons. First talk by Dr. Linette Morris. Over to Dr. Linette Morris.
Today, we'll be dealing with how to give anesthesia for a retrosternal goiter. Here we have a patient who is 32 years with history of thyroid swelling of 3 years duration. She gives history of tremor in hands, heat intolerance, menstrual disturbance, diarrhea, and significant weight loss. She has a drug history of having taken propranolol 40 milligram per day and carbimazole for 5 milligram for the past 6 months. On examination, there is a large thyroid swelling measuring about 10 into 8 centimeters in front of neck, which moves with deglutition. The lower border of the swelling can be felt. Pemberton's test is negative. She has a heart rate of 80 per minute, which is regular. BP of 120 by 70 millimeters of mercury. There is evidence of tracheal shift to the left. Otherwise, examination of the airway appears normal. Her investigation showed a hemoglobin of 11 gram%. X-ray chest showed evidence of tracheal deviation. ECG appeared normal. X-ray neck AP view showed a tracheal deviation to the left, and lateral view showed evidence of tracheal compression. CT thorax showed tracheal tissue extending for about 15 millimeters below the upper border of the sternum. There was evidence of tracheal compression. This patient, who is diagnosed to have a retrosternal goiter, is now posted for an elective thyroidectomy. What are the clinical signs and symptoms of retrosternal goiter? Retrosternal goiter may appear asymptomatic in 20 to 30% of the patients and may present as a slow-growing mass, which becomes evident as an incidental finding in the X-ray chest. Most common symptom is a cervical mass, which occurs in 40% of the patient with evidence of tracheal deviation. It may present with pressure symptoms such as dyspnea due to compression on the trachea, dysphagia due to compression on the esophagus. Compression of the recurrent laryngeal nerve may produce hoarseness of voice. There may be symptoms of superior vena cava compression or even Horner's syndrome in certain cases. 10% of the patients may show evidence of thyrotoxic features. Long-standing cases of retrosternal goiter may produce a life-threatening complication such as airway obstruction. This may be due to hemorrhage within the gland, or it could be due to an acute laryngeal edema. Hewins and colleagues have classified retrosternal goiter depending upon the anatomical location of the enlarged thyroid gland and have made suggestions for the surgical approach when designing to do a thyroidectomy. In grade 1 patients, the enlarged thyroid gland extends above the aortic notch and a cervical approach is sufficient. In grade 2, the enlarged thyroid gland may extend between the aortic arch to the pericardium, and a manubriotomy may be essential. While in grade 3, the enlarged thyroid gland may extend below the right atrium, for which a sternotomy may be indicated. What are the investigations to be done in these patients? Hemoglobin to rule out anemia, TC-DC-ESR to rule out infection and agranulocytosis, since these patients are anti-thyroid drugs. Platelet count, because when they start treatment with carbimazole, platelets may be reduced. Serum creatinine has to be done, along with serum electrolytes such as sodium, potassium, and calcium has to be done. Blood sugar, blood grouping, and cross-matching has to be done. An X-ray chest to know the extent of lesion and also to know the evidence, which may show evidence of tracheal compression. X-ray neck, AP, and lateral view, which will show evidence of tracheal compression or deviation. ECG to rule out any evidence of ischemia or arrhythmias. Indirect laryngoscopy to assess the mobility of the vocal cords. And a thyroid function test. And also CT thorax if there is evidence of more than 50% compression of the trachea on an X-ray chest. 2% of patients with retrosternal goiter may require surgical access other than a standard Hawker's collar incision. Performance of airway examination as in any other case, which includes a Mallampati classification, neck movement, evidence of any protruding incisors, thyromental distance, sternomental distance has to be done. What are the anesthetic goals to be taken care of? A difficult intubation is to be anticipated. Massive blood loss can occur. Prolonged operating time, particularly if a sternotomy is being planned. Post-operative tracheomalacia in case of long-standing large goiters. These patients are prone for airway problems. Airway problems may begin with induction of anesthesia, a difficult bag and mask ventilation, difficult tracheal intubation, difficult ventilation, and above all, complete airway obstruction can occur during the induction of anesthesia. Anesthetic management. Prior to anesthetic management, the patient should be optimized. Both patient should be symptom-free as well as patient should be biochemically euthyroid. A sedative pre-medication should be avoided in these patients because of the potential for a difficult airway and possibility of respiratory obstruction. Pre-oxygenation should be performed with 100% oxygen, which gives enough time to gain access for a difficult airway. Choice of airway management in these patients would be an awake fiberoptic intubation in the first place, followed by blind nasal intubation, either awake or an inhalation method. Now the advantages and disadvantages of an inhalation induction. Inhalation induction has the advantage that it is a slow process and it preserves spontaneous ventilation. Automatic cessation of drug delivery can occur if airway obstruction occurs. The disadvantage is that in a few patients, failure of technique can lead to complete loss of airway and failure to ventilate the patient. Intravenous induction has been safely used in large goiters. However, large, severely symptomatic patients, the use of intravenous induction is lacking, data is lacking. In such patients, sudden loss of consciousness can lead to loss of muscle tone and total loss of airway, leading to airway obstruction. But what are the advantages of neuromuscular blockage? It has the advantage that it provides better intubating condition. However, the patient cannot be woken up if we are unable to intubate the patient. So this prevents most of the anesthesiologists from using a neuromuscular blockade. If a neuromuscular blockade is deemed necessary, a short-acting muscle relaxants like suxamethonium can be used. What is the danger of using general anesthesia in patients with retrosternal goiter? During induction of anesthesia, there is reduction of lung volume by 500 to 1000 ml. In addition, there may be relaxation of the bronchial smooth muscle, which decreases the caliber of the airway. It also, with induction of anesthesia, there is loss of spontaneous diaphragmatic movement, which leads to a decrease in the transpleural pressure, which again leads to a decrease in the airway diameter. The choice of endotracheal tube is a reinforced armored tube. Simple PVC tubes may kink under the drapes. However, a ring adhere Elvin tube, the RAE tube, North Pole tubes can be used safely in these patients. Positioning is important. A 15 to 25 degrees head-up tilt, a sandbag under the shoulder, occiput which is supported by a ring, arms placed by the side of the patient, and padding of pressure points and protection of the eyes are important. Monitors include the usual monitors like ECG, NIBP, SpO2, and capnography. In addition, temperature and neuromuscular monitoring has to be done. If a sternotomy or if massive blood loss is anticipated, invasive monitors like central venous pressure and invasive blood pressure monitoring has to be done. What are the intraoperative complications these patients are prone? Excessive blood loss, accidental endotracheal tube displacement, a venous air embolism can occur, and thyroid storm, though rare, is a fatal complication. Tracheomalacia occurs in large goiters which have been there for a long duration of time. This is because of pressure atrophy and erosion of the tracheal rings, which leads to collapse and respiratory obstruction. Reintubation and ventilatory support is usually required. What are the postoperative complications these patients can have? Airway obstruction due to laryngospasm and laryngeal edema. Vocal cord palsy, this is due to nerve injury. Mainly, the recurrent laryngeal nerve may be involved, and if it is bilateral, it can cause stridor. The superior laryngeal nerve may also be involved in 3 to 5% of the patients. Superior laryngeal nerve provides supply to the cricothyroid muscle, which is the sole tensor of the cord, and which can lead to respiratory problems. Expanding hematoma can also lead to airway obstruction. Tracheomalacia is yet another cause of airway obstruction. Residual sedation and neuromuscular blockade can lead to airway obstruction. Negative pressure pulmonary edema, though rare, is a fatal complication which can lead to airway obstruction. In about 10 to 15% of the patients, the hypoparathyroidism and hypocalcemia can occur. This is due to accidental removal of the parathyroid gland during a thyroid surgery, and it can manifest as perioral tingling. It can produce muscle twitching, seizures, and it should be treated with intravenous supplementation of calcium gluconate or calcium chloride. Thyroid storm, rarely seen, is a fatal complication. It occurs in poorly prepared hyperthyroid patients. Although the onset is 6 to 24 hours after surgery, it can occur in the intraoperative period. Clinical features include hyperpyrexia, tachycardia, hypertension. Precipitating factors include infection, trauma, surgery. Differential diagnosis, malignant hyperthermia. Treatment involves intravenous hydration, cooling the patient, decrease the heart rate by using beta blockers, IV propranolol or esmolol. Propyl thiouracil 250 mg 6 hourly orally or via the NG tube. Sodium iodide 1000 mg given over a period of 12 hours, which prevents the release of any thyroid hormone which has been already prepared, synthesized in the gland. Cortisol may be given 100 mg IV 8 hourly because it may be associated with adrenal cortical insufficiency. Correction of precipitating factors such as infection should be undertaken. Mortality is around 20%. Postoperative pain and postoperative nausea vomiting are important problems seen in patients who have undergone thyroidectomy. Pain may be managed with multimodal analgesia, superficial cervical plexus blockade, infiltration of the wound with local anesthetics and opioids, and non-inflammatory, non-steroidal anti-inflammatory drugs may also be used. Postoperative nausea and vomiting may be treated with antiemetics such as metoclopramide, dexamethasone, or with ondansetron. Thank you.
Thank you, Dr. Morris. Next, we have Dr. Ashish Karthik. Over to Dr. Ashish.
Hello. 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 Yeah, this is for ISA, the topic, what you're going to discuss. This is for the initial editing. I hope everything is okay. Just checking out my video. So, hi friends. What we are going to see in next 15 minutes is about a COPD patient with DU perforation coming for emergency laparotomy. Basically, I have few assumptions to make that this is patient is seen in a typical medical college setup where I am working, and there is no scope for laparoscopy for a DU perforation. And patient is usually seen just outside the doorstep where you don't have much time to optimize. And usually the presentation will be a thin man with a barrel-shaped chest coming and lying outside, telling that 2 days I'm having pain, local reference to a local hospital, and coming back here waiting for the TrueNat and for basic investigation has been rolled into the EOT, and where our JR as well as the MO is going to see this patient. So usually he will be accompanied by an innocent and yet an ignorant bystander, and probably a house surgeon as well. So this is a setting. Now what you're going to discuss in the next 15 minutes is about the preoperative workup and preoperative assessment, intraoperative management, and postoperative period, how you are going to manage this case. Now, preoperative workup essentially has got three components, that is assessment, optimize, and plan. Assessment, optimize, and plan. So essentially what you are trying to do in assessment, basically the assessment is done on few things like history, clinical features, and investigations. History, clinical feature, and investigation. Now, for easy remember, for any emergency case, just remember like that. When you want to do that, remember in assessment, the PSC doctor. That means primary, secondary, comorbidities and airway, drugs, and risk assessment. This is PSC doctor. It's a simple code which you can remember. Now, what is about the primary disease in this case? It is a COPD. It is a duodenal ulcer which has been perforated. So it is a major surgery, and it is something has to be done as an emergency basis. These are the two aspects which you should remember. The extent of the disease, is it that much of toxic? Whether it has gone to septicemia is the next condition which you need to understand. See for the hemodynamics. Essentially what I was trying to tell you, you need to look into history, investigations, as well as a clinical finding to assess all the steps. Coming to the secondary, in secondary assessment, is in this case in particular, it is the COPD. Now, as you know, there are three types of COPD, which you will be essentially seeing a mixture of these, because you don't see a typical blue blotter or a pink puffer in this condition. If most of the time you get a smoker who has been perforated for 1 or 2 days, a thin and with a barrel-shaped chest guy with minimal scattered crepitations. So we have to see that patient as a total. And one more point which need to remember whenever you see a DU perforation is see whether the patient has got a drastic fall in the weight or emaciated in another 1 month of the previous 1 month, which in turn tell you that you are not at all just dealing with a duodenal ulcer. It always comes into back of my mind that I'm going to deal with a malignancy, an underlying malignancy below this DU perforation. So I'll be prepared for that. So essentially you will be looking at the saturation, pre-op saturation, essentially very important. You will get an X-ray to see how much extent, whether what is a flattening level, how much is a COPD emphysema present, whether there is a gas behind, and things like that. If you are lucky, you will get an ABG, which will tell you how much about the PCO2, and see the bicarbonate, how much it has compensated. Essentially, you get a high PCO2 and you will get a bicarbonate compensation most of the time. If you are having a good setup, working a good setup, you have good method to assess with a handheld spirometer. Otherwise, you will have to just satisfy it with the bedside pulmonary function test. And you know, bedside pulmonary function test, the most common things what we do is cough test and single breath count. Ask the patient to take a deep breath, ask him to count from 1 to 40. Most of the time, you will not be able to do that. If he can count anything above 15, that means okay, his vital capacity is good. But most of the time, he will not be able to do so, especially in such a scenario which we have presented. So that is about the secondary PS. Now come to C. C is about the comorbidities other than COPD. essentially these patients will be a smoker, will have some coronary artery disease, has got some liver problem, because alcoholism is a very common association, as most of us know. And along with that, they will be anemic, and if they have got an underlying liver disease, they will be having coagulation abnormality, as which you need to assess, because it is going to determine your modality of anesthesia. So when you are assessing the cardiac system, always make sure whether the dyspnea is due to exclusive. Never brand them as a COPD patient coming with dyspnea. Don't think that is exclusively dyspnea due to a respiratory cause. It can also be due to a cardiac cause, because how to identify? That's a simple thing. Remember 3 P's. One is pain, palpitation, and PND. If these 3 are present, it is of the cardiac origin. If not, just a dyspnea is present, you can think it is more of a respiratory disease. Even with an extensive severe COPD, patient can have features of cor pulmonale, like a tender hepatomegaly or bilateral pedal edema, and some amount of basal crypts also, if there is an associated LVFS coming with associated with an RV hypertrophy and RV failure. So essentially what I'm trying to assess, what is a cardiac situation, how is its electrolytes, because that is also going to affect my drugs, especially scoline and other management. So see what is the potassium level, because most of the time they get deranged, and if it is an elderly patient, there is every chance that these patients can have hyponatremia as well. Coming to the drugs is the next important. Of course, comorbidities is not complete with an airway. Remember, just do a quick airway examination as well, because you are going to do most of the time rapid sequence induction and intubation. Now, regarding the drugs, hospital admissions, number of hospital admissions the patient had is an important clue to say that whether your patient is a stable COPD or an unstable COPD. If the patient was on home oxygen therapy for some time, has got recurrent hospital admissions, had to put on IV steroids for controlling, then you are dealing with an unstable COPD, which you need to be really careful. Infection is another condition which you need to address, whether the patient has got recurrent infection, as they put on antibiotics. Now, after that, see for the risk assessment. See, most of the time you will not be getting a goal criteria to assess the risk in such cases, because you will be just left out with a few clues, clinical clues, especially if you've got an elderly of more than 60 years who has got multiple system involved, who has got a decompensated COPD, who is unstable hemodynamically, are going to have a difficult post-op or even intra-op. But if you get an ABG, try to see whether the ABG is within the PCO2 is above 45. If the PCO2 is above 45, you should be thinking that you are going to deal with a difficult case. If the PO2 is less than 50 or 55 in certain situations, as the PCO2 comes down, you are having more and more trouble. So that is another one which you will easily get from an ABG. So apart from that, see whether the patient is obese, having a significant comorbidities. These are all common findings which you will see with while assessing the risk in patients. Now, after that, how to optimize this patient? It all depends upon how much time do we have to optimize these patients. Most of the time, you don't have much of time to optimize them. So adequacy of therapy, essentially what you will be trying to do is just to complement whatever therapy they have been providing. See, you will be, most of the time, will be allowed to give just a nebulization with a beta-2 agonist like an albuterol or a salbutamol most of the time, which has not been done. In turn, you get albuterol, or you can even nebulize them with steroid. If the patient is having a puff, their MDI, along with that, you can ask them to get 2 or 3 puffs before they enter into the theater. That is what I usually do. If the patient has got has been receiving steroid for some time, it is always better, though there is no clinical criteria or clinical studies which say this is the amount of time where you have to supplement with steroid. But most of the time, if you think the patient is in a moderate to severe bad situation, it is better to supplement. You can either use 100 mg of IV hydrocortisone, or if you use the choice can be Dexona as well, because 4 mg of Dexona IV has got 2 options. One, they will take, both the steroids will take care of the stress response of the surgery. Along with that, they will also take care, Dexona will take care of the problem of post-operative nausea, vomiting. So if you have ample time, try to correct the electrolytes, at least potassium if it is below 3, and try to correct the coagulopathy if at all, because the surgeon as well as you will have problem in managing this case intraoperatively and postoperatively, because you are going to determine on your epidural or your regional anesthesia method depending upon the coagulation profile. So that is about the optimization. Now, how do we plan? That's the third assessment, optimize and plan. That is the primary. Now, plan is the simple code is AC square. Now, what is A? You, based on the situation which you have assessed, you classify them into ASA 3 and 4. Most of the time, if you have a compensated disease, it is 3, and uncompensated, more critical stage patients, you put them on ASA 4. Now, determine which anesthesia is going to work for him. If it is in our case, there is no question. You are having a DU perforation, which I know there are centers which they do quick surgeons while when they go above, just supplement with some amount of ketamine or a small opioid and get away the surgeon. But for a discussion, the best option, whenever you have a patients like this, always go for GA with regional technique. Now, if the patient is ready, hemodynamically stable, I would always charge the epidural. If not, it is always better to put the epidural, and if hemodynamically unstable, go for a bilateral tap after induction to provide the pain relief, at least in the parietal bone. So that will be the management which you are going to do. So in this case is probably GA with epidural or GA with bilateral tap, depending upon the situation. Now, what are the complications? You should also predict the complication which can happen to the patient, like bronchospasm, pneumothorax, arrhythmias, etc., and plan accordingly. At least you should have a suction ready, a chest stethoscope around, and an ambo bag, and drugs which helps you in tide overing that situation. And based on all this assessment, it is always better to get a consent for this patient. Consent includes that you are going to deal with a patient who can have an intraoperative problem, as well the patient can have postoperative ventilation. So these are the aspects which you will definitely see before in the preoperative period. Now, what you do in the intraoperative period is also important. You classify them into two aspects. One is anesthetic management per se, and two, management of complications. Now, what is the assessment of anesthetic management? Essentially consists of putting an IV line. I will always prefer to have two IV lines in such cases, essentially the wide bore ones. And then when you think about pre-medication, it is always good to pre-medicate this patient. Stress of steroid, which we have already discussed in essential cases. Number two, glycopyrrolate to reduce the secretions. And number three, but beware, if the heart rate is quite high, then you can rethink about that. It is case-to-case basis. Then small amount of opioids like fentanyl. Morphine is not a choice in this case because of the bronchospasm associated. Fentanyl is a good option, but always remember it is given in increments, and fentanyl opioids are well known to aggravate the respiratory depression and sedation of these patients, along with the basal excitations that can produce. Now, if the patient is ready, is competent or stable, we can go for an epidural, and a mixture of opioid with ropivacaine or a bupivacaine analgesic dose is probably the best option. And before taking up for the induction, the next primary thing which you need to do is the pre-oxygenation, which is very important in these cases, because pre-oxygenation usually 3 to 5 minutes is not to be followed, which you need to keep it for longer duration. Like 3 minutes is not sufficient in a patient with COPD. You need to give at least for 5 minutes. Now, if you are in a very quiet hurry situation, we are going for large vital capacity breaths. More than 4, give it around 6 or 8 breaths, whichever is possible, because they don't take deep breaths most of the time. So try to provide maximum time of pre-oxygenation, because you're going to have issues after that, because hypoxia is an issue before you stabilize the patient after intubation and things like that. Now, we don't usually practice putting a pro-seal LMA and the regional technique for managing these situations in our institution. So I don't discuss supraglottic airway in this, but remember that can also be an alternative in situations like this, where you feel a difficult airway and managing this patient with an epidural and a pro-seal LMA or a second generation supraglottic airway. Now, induction is always rapid sequence induction, because you got an unprepared patient, and the options you have is ketamine and propofol. You don't use thiopentone. Neither opioid induction is preferred. Now, because the best option is propofol. Now, how do you select whether propofol or ketamine? If the patient is hemodynamically unstable, it is ketamine has got an upper hand. If the patient is reasonably stable, propofol has an upper hand. Propofol has got an added advantage that they blunt their airway response. So if you are going to put a supraglottic airway and produce, probably propofol is a better option. No, but usually we use a combination of these. In fact, you can put it as in a combination of ketamine and propofol, depending upon the hemodynamics. That's my option. Now, relaxation, as it is a rapid sequence induction, you can the most common thing what you want to do is scoline, provided the potassium is low. provided potassium is normal. Now, otherwise, you can go for rocuronium. And if the patient doesn't have that issue, they have maintained reasonable time of NPO before taking up the case, then you can even think of cis-atracurium. Atracurium is not a very good choice because it can have histamine release. Picronium is another option. Now, gentle laryngoscopy is being performed most of the time in such patients because lighter planes can be dangerous. So before scopy, there are two things which you can do. Add a small dose of propofol. Apart from the 2 milligram per kilogram, you can add to a 0.5 milligram per kilogram just before the scopy. And also you can do that before that, around 90 seconds before, you give your 1.5 mg per kg of lignocaine for attenuating the stress response. Now, after doing the scopy and intubation, there are certain centers, of course, before putting the tube, they do a lignocaine spray, which with a 4%, which I don't practice most of the time because there are studies which say that you give a spray and you can trigger a spasm. So we don't usually perform. We just go with the additional dose of, that means taking down the patient or deeper the patient with an added dose of 0.5 mg of propofol, and along with that give a small dose of lidocaine, the dose of lidocaine which we have already discussed. Coming to the maintenance phase, it is always maintenance with ISO and SIVO. And SIVO is better choice. If not available, you can go for ISO. The other options like halothane, desflurane, the choice is not a very good option here because it can induce bronchospasm and it is pungent, so it can induce spasm. So the choice is either ISO and SIVO. SIVO, if you have good, if not, go for ISO. Dexmedetomidine, depending upon dexmedetomidine bar propofol, depending upon the patient's your institutional protocol and the patient's hemodynamics, because both can produce hypotension along with the bradycardia. Depending upon that situation, you need to titrate. Regarding nitrous oxide, it's a controversy. If you see the X-ray is quite high, X-ray is it's an expanded chest, there is a presence of bulla, try to avoid nitrous oxide at the initial phase, and always make sure that you have got air to supplement. If your center doesn't have that, it is at times you'll have to go with nitrous oxide as well, but then you'll have to see about the peak inspiratory pressure more stringently. Otherwise also you have to go, but in these situations you have to go for much more careful aspect because you are in at times chance to rupture a bulla. Now, regarding the ventilation, that's the most important aspect in ventilating any patient with COPD, because there is 2 points which you need to keep in mind. One, see whether you are not developing a high peak inspiratory pressure. At any cost, you need to keep it low. Below 50 is the best option. And then keep the plateau pressure also below 30. And how do you do ventilation? It is there are two options. Either you can go for volume cycle ventilation or pressure cycle ventilation. Pressure cycle is probably the best option, but I don't know how many centers have got that pressure control ventilation available in the anesthesia machine. If you have it, is good, but just have a look whether you are delivering the reasonable amount of tidal volume in such situations. Now, volume cycle ventilation, it is volume control ventilation is fine. Then see for the pressure developing into the system. Always make sure there is no intrinsic PEEP developing. If at all there is an intrinsic PEEP developing, make sure it doesn't go into a higher level. If there is an significant intrinsic PEEP developing, you have to check it with the expiratory hold and then add on to the extrinsic PEEP so that you get a better tidal volume and reduce the work of breathing. So while ventilating, make sure you provide a good IE ratio. That means usual 1:2 has to be changed either to 1:2.5 or 1:3. Reduce the respiratory rate in order to do this, or always make sure whether you are not developing an intrinsic PEEP while ventilating. Now, if the patient has not been put on epidural, it is always good that you put the patient on bilateral tap because it doesn't compromise much on the hemodynamics. IV fluids, the key is not more. Keep the patient optimal or bit low, not more. Don't fill the patient too much. While reversing, neostigmine itself can induce spasm, so it's better to mix with a glycopyrrolate as we already do. And extubation, the typical standard is the teaching is to extubate it in deeper planes to avoid bronchospasm. But again, also here we'll have to use your judgment. When you extubate deep, of course, you are saved of bronchospasm that can happen. But at the same time, make sure you are not in a position to re-intubate, or you are not getting into a situation where you have to re-intubate the patient because the patient has not fully come out of anesthesia or the muscle relaxant is not yet over. So you have to judge the situation. So theoretically, extubate the patient deep. If you are planning to ventilate, it's fine. Otherwise, you have to judge the situations. Now, post-extubation, of course, your patient is taken adequate care and shifted to post-operative recovery room. There are at times complications which can encounter during performing anesthesia. The most common complication is bronchospasm. Pneumothorax is another option, development of autopeep, arrhythmias, and ischemia. These are the common things which you come across. When you have a bronchospasm, how do you diagnose? The first thing is increase in the peak inspiratory pressure, fall in saturation. Then you will see there is a scattered wheeze. How do you do? Deepen the plane. That's the first thing. Deepen the plane of anesthesia, either by volatile agents or additional dose of propofol, depending on the hemodynamics. Make sure there is no secretions. Tube has not migrated anywhere. There is no kinking like that. And then you have fall in saturation following that. So try to make it into 100%. And then you can nebulize through the endotracheal tube. Ultrasonic nebulizers you can use if you have your center have that. Pneumothorax is a much missed one, very commonly. In this situation, the patient will be just having a fall in saturation towards the late, but before that you will have an increased airway pressure. Then you will have fall in saturation, auscultate and find out it is bilateral. If you have not recorded anywhere or you have not recognized the problem anywhere during this time, then the patient manifests as hemodynamic instability. So when your patient manifests as hemodynamic instability, always think you are not missed out on pneumothorax. We have already seen the management of autopeep, and then arrhythmias are common in this situation because hypercarbia is a common association. Ischemia is common because the patients are smoker, and you can have ischemic state. Most common ischemia you can have is an ST changes along with few T inversions that can happen. Now, coming to the third aspect is a post-operative period. In the post-operative period, you have two aspects to discuss. One is post-extubation, what you do, and what are the complications you have. Now, post-extubation, the most common thing what you need to remember is that patient need to have a multimodal analgesia because good inspiration is very good. The effort is good to avoid atelectasis and to have easy early mobilization. So at times you will have to go with a continued ventilator support for some time, like either it in the form of a non-invasive ventilation or a CPAP or a BiPAP. But always make sure whenever you are providing this, the peak airway pressures are not hampered or it is not breached, so that you produce a pneumothorax due to that. Now, positioning is important. Post-extubation, if you are extubated, make him propped up a bit so that there will be much better compliance for the patient, and easy mobilization, as early mobilization is very helpful. Now, always remember, oxygen is a double-edged sword in such situations, because if you provide too much of oxygen, it will produce an oxygen-induced hypercarbia, or patient just stop breathing. There can be a ventilation perfusion mismatch as well associated with increased oxygen therapy. So beware of the oxygen. You should be very happy with if the patient is saturating anywhere between 90 to 90, 93 or 95. So that is a reasonable saturation. Although theoretically you say 88 to 92, but I am not very happy with the 88 patient post-operatively. So what I will suggest, my option will be to keep it anything above 90 or between 95. Above 95, it's well and good. Now, drugs. Always make sure the patient receives a regular dose of antibiotics. If the patient was on steroid, continue the steroids, and if there is any bronchospasm, continue the beta agonist after that. Lung expansion maneuvers like deep inspiration exercises, and then chest physiotherapy, incentive spirometry, etc., are all very, very important in such cases. So you should always remember the complications in the intraoperative period can extend into the postoperative period as well, and you should always be looking of complications like atelectasis, patient having stopping of breathing, DVT, etc., in such COPD patients. So this is in nutshell, how do you manage a patient with a COPD coming to your emergency for laparotomy. So I should thank all the enthusiastic viewers for this. Along with that, Dr. Manjit and the scientific team and the organizers who has done such a wonderful job in organizing this and teaching us all this in the middle of the pandemic. And thank you for all the efforts which you have taken. Thank you. Doubts?
Thank you, Dr. Ashish. Next, we have Dr. Naveen Malhotra. Over to Dr. Naveen Malhotra.
Good afternoon. Heartiest congratulations to all Kerala ACNs on 1st November Kerala Day, and also to the Haryana ACNs, because Haryana was also formed on 1st of November. I am thankful to the organizing committee. Today I shall be talking about chronic pain management from postgraduate perspective. I bring with myself greetings from Pain Management Center, the Dard Nivaran Kendra at PGIMS Rohtak, which I am heading. I am happy to share with you that we have got a very heavy and busy pain management center, and number of patients coming are like that of any gynae, medicine or orthopedics OPD. Pre-lockdown, I used to have 3 OPDs, Tuesdays, Fridays and Saturdays, around 150 to 175 patients per OPD and 30 to 40 blocks in the pain OT in the pain management center. And then separate pain OTs on Mondays and Thursdays, where we administer fluoroscope guided blocks around 20 to 25 per OT, and UG guided blocks are given on Wednesdays. This is the dedicated pain OT in the pain management center, 6-bedded pain recovery room, and a good space for holding the patients around 50 to 60 at a time. But things changed after lockdown. 2 months there was no OPD, only teleconsultation, and calling those patients who required care in the surgery operation theatre. OPD restarted on 22nd May 2020. Initially it was once in a week with maximum allowed patients, 100 patients per day, with all the restrictions and the guidelines of running an OPD were followed, whether it was social distancing and wearing protective gears and hand hygiene. Since July, OPD has been restored to the pre-lockdown period. Coming to the chronic pain, International Association for Study of Pain has revised the definition of pain on 16 July 2020, and it states that pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. There are 6 notes to this definition of pain. Coming to the topic, chronic pain management and postgraduates, the erstwhile MCI and now National Medical Commission has designed a very beautiful competency-based postgraduate training program for MD anesthesiology in September 2019. It states that the MD anesthesiology postgraduate must possess and demonstrate abilities to manage chronic pain and practice different modalities of chronic pain management, including pharmacotherapy, non-opioid analgesia, interventions, nerve blocks, spinal opioid treatment, neuroablation, neuroaugmentation, and physical therapies, psychotherapy, and cognitive behavior therapy. The student must have demonstration of following abilities, assessment of patients with chronic pain, including proper history taking, appropriate physical examination, and interpretation of relevant investigations. He should be able to differentiate between acute and chronic pain and classify chronic pain further into nociceptive pain, neuropathic pain, and mixed pain. He should have sound knowledge of cancer pain and palliative medicine. The student must also be taught about knowledge of pain pathways in detail and knowledge of theories of pain in detail. The syllabus has also been beautifully defined as far as pain is concerned. In the first year, the MD student should be introduced to acute and chronic pain and the pain management modalities. In second year, he should be taught about care of terminally ill and hospice management. And in the third year, he should be able to taught about chronic pain therapy and therapeutic nerve blocks and other modalities of pain management like acupuncture and acupressure. He should be posted for at least 1 month in pain clinic during his, preferably in second year or between 6 to 24 months of his MD tenure. There should be exposure to multimodal approach to pain management, including pharmacotherapy, interventions, psychological support, exercises, and alternative medicines. The student should possess knowledge and principles of management of nociceptive pain, including myofascial pain, low back pain, infractable angina, burns, chronic pancreatitis, and PVD, peripheral vascular disease. Let's take one by one. Myofascial pain syndromes. Myofascial pain syndromes are characterized by myofascial trigger points, and pressure on these active trigger point induces or reproduces some of the patient's pain complaint. Trigger point injections are the cornerstone of those patients who do not respond to the conservative treatment of ultrasonic therapy, massage, and sprays, and muscle relaxants and analgesics. with the trigger point injections are given with a finer needle, with local anesthetic, rinsed with a small amount of corticosteroid with fanning technique. So these are the trigger point injections of the upper back, and you can see that they are given in the fanning technique, perpendicular, then lateral, and then medial. Trigger point injections can also be given for the neck paraspinal muscles, upper back, and lower back. We have to distinguish between myofascial pain syndromes and fibromyalgia, which is a syndrome characterized by widespread pain in muscles, ligament, bursa for more than 3 months with no specific cause of pain. These are characterized by tender points. This is the old diagram of fibromyalgia tender points. And there are additional symptoms of poor sleep, headache, and inflammatory bowel syndromes. Typically, the patients are young females and symptoms wax and wane over a period of time. There can be good days and bad days. There can be good weeks and bad weeks. Treatment is complex of anti-epileptic treatments like gabapentin and pregabalin, combined oftenly with tricyclic antidepressants like amitriptyline or duloxetine, and with analgesics like NSAIDs and for long-term tramadol. Patients also do self-management therapies like breathing exercises, meditation, aerobic exercises, and patient support groups like fibromyalgia support groups. Back pain. 60 to 70% of the patients who come to pain clinics suffer from musculoskeletal pain, and out of that, back pain is the most common symptom with the patients present. We should take a thorough history and clinical examination of a patient with a back pain to see which nerve root is affected, which are the dermatomes which are effective. MRI is done very commonly because Cary's spine is not uncommon in India. And initial treatment is of conservative therapy comprising of analgesics, neuromodulators, muscle relaxants, physiotherapy, and precautions. And 80 to 85% of the patients respond to these treatment modalities. The commonly used neuromodulator drugs are gabapentin and pregabalin, or a combination of gabapentin and pregabalin with nortriptyline. Those patients who do not respond to the conservative therapy, they are given interventions. And the most common one is epidural steroid injection. And the curriculum says that the MD student should practice epidural steroid injections at all levels. And they should also know about long-term epidural catheterization. So selective nerve root block is the most common intervention which is performed in patients with low back pain. And MD students should observe and assist these blocks. This block is given at the affected nerve root through the transforaminal approach, and you see that if it is L4 of the right side, you are injecting at the level of L4 and seeing the nerve root with the dye, and there is an anterior epidural spread. The other routes which the MD student should know are the caudal epidural steroid injection. In anesthesia, they are given under USG guidance or anatomical landmarks guided, but in chronic pain patients, they are either given under fluoroscope guidance or under USG guidance. So this is a patient in prone position under fluoroscopic guidance. The needle has gone into the epidural space, and this is the dye spread which is coming. And typically we see a Christmas tree appearance. This block is good for lower levels of herniated disc like L5S1 or maximum L4, L5. These USG guided epidural blocks are also been commonly done. Initially, the probe is placed in transverse position, then in longitudinal position, and you can see the sacral cornu, sacral coccygeal ligament, the sacral hiatus, and the sacrum. And then in the other view, you can see the caudal epidural space. Put the needle inside and see the needle into the epidural space, and then you can put a color pattern to see the color mode to see the mosaic pattern when you are injecting the drug into the caudal epidural root. The other routes which is commonly formed are the midline interlaminar epidural block, which you can give in under lateral position or sitting position or prone position. Interventional pain specialists usually give it under prone position and under fluoroscopic guidance. And here you can see the spread of the dye into the epidural space. You can give it under sitting position also. Another route is the parasagittal epidural block, where you inject in the far lateral aspect of the epidural space, especially useful if a particular side nerve roots are involved, like right side L3, L4, and you can see that anterior epidural spread of the drug is effectively achieved. The student should know about the thoracic also and the cervical also, route of epidural injection. The cervical root is commonly used for cervical pain with the radicular component, and it can be performed under a prone position or in a sitting position also, usually performed at C71 or C7, which is the most wide space available. And at times, epidural catheter can be introduced for 2 to 3 days. The student should know about the principles of radiofrequency lesioning, whether it is a pulsed RF or a conventional RF, and you should know about the differences between the cooled RF and the conventional RF, and the common indications and the technique of radiofrequency lesioning, like for medial branch block for the facet joint pain, stellate ganglion block, lumbar sympathectomy block, trigeminal neurectomy block, genicular nerve block for osteoarthritis of knee pain, and superior hypogastric plexus block for carcinoma uterine pain. Covering from myofascial pain and low back pain, patients may have intractable angina, non-ischemic pain, following whether CABG or PTCA, still patient may have pain, and we have to manage these patients and differentiate between the muscular component of the pain as well as the ischemic component of pain. Patient with burns may have persistent pain, and these have to be managed. For chronic pancreatitis, usually intervention done is a celiac plexus block with local anesthetic and corticosteroid. And for peripheral vascular disease of the lower limb, it is done by lumbar sympathetic block along with drug treatment. Moving from nociceptive to the neuropathic pain, the student should have sound knowledge of principles of management of neuropathic pain, like phantom limb pain, postherpetic neuralgia, complex regional pain syndromes, and trigeminal neuralgia. Initial line of treatment is pharmacotherapy, and the commonly used drugs are anticonvulsants like carbamazepine, gabapentin, and pregabalin, combined with antidepressants like amitriptyline and duloxetine, and some topical agents or opioid and non-opioid analgesics. Trigeminal neuralgia, sudden sharp shooting pain lasting for a few seconds to minutes in occurring 1 or 2 divisions, V1, V2, V3 of the trigeminal nerve. If these are the blocks of supraorbital and supratrochlear nerve, if pain is in that particular division, it can be done under anatomical landmark guidance or fluoroscopic guidance. Usually it is an OPD procedure. Postherpetic neuralgia can also lead on to trigeminal neuralgia, herpes zoster infection. So this is herpes zoster affecting the supraorbital and supratrochlear division of the trigeminal nerve. If pain is there in the infraorbital nerve, then infraorbital nerve block is given. We have done compared radiofrequency with injection of local anesthetic with corticosteroid and found that radiofrequency lesioning of infraorbital nerve is not that effective. Radiofrequency lesioning is done under fluoroscopic guidance. If pain is there in the mental nerve, you block the mental nerve selectively. And for mandibular and maxillary is V2 and mandibular is V3. Initially, you go for the diagnostic blocks, and if patient has pain relief, then you go for radiofrequency lesioning under fluoroscopic guidance of maxillary, mandibular, or at times both the divisions may be effective. You can go for conventional radiofrequency, pulse radiofrequency, or combination of the two. If pain is there selectively in the inferior alveolar nerve, you can block the inferior alveolar nerve also. Moving down from trigeminal neuralgia to the postherpetic neuralgia, these are the patients who have common and uncommon presentation sites. Face and thoracic is a common site, but upper limb and lower limb is an uncommon site. These scalp is also seen at times. And you can go for simple maneuvers like at the uncommon site, deep infiltration of the lesions. And if selective nerves are involved, then you, like in thorax, you can go for intercostal nerve blocks, thoracic epidural, and these are quite effective. We can have patients with scar neuralgias and enterapid neuropathy following surgery, usually following cholecystectomy and lap cholecystectomy, occurring upper, slightly occurring upper and near to the subcostal region. Deep infiltration of lesions done twice weekly for 5 to 6 settings provide effective pain relief of around 50 to 60%. Complex regional pain syndromes, a difficult entity to treat, can occur following brachial plexus injury, or it can occur following upper or lower limb fractures. There are dystrophic changes, temperature changes, hair changes, and skin changes are occurring. And these can occur following, patient can present with phantom limb pain also, or stump pain also following amputations. Treatment modalities initially include drugs, gabapentin and pregabalin commonly used, combined with physiotherapy, psychological therapy, and occupational therapy. And if these modalities don't succeed, then we go for stellate ganglion block under USG guidance or fluoroscopic guidance. C6 chest tubercle, see the spread over the longus colli. You can go for a local anesthetic diagnostic block followed by radiofrequency lesioning or repeated blocks of local anesthetic and non-particulate corticosteroids like dexamethasone. Done under fluoroscopic guidance commonly, and you can see for the Horner syndrome and change in color of the affected side, it becomes more hyperemic. If it is affecting the lower limb, then we can go for the lumbar sympathetic block, initially diagnostic, followed by radiofrequency lesioning under fluoroscopic guidance. And then you can see for the change of the color of the affected limb also. Temperature increases, blood flow increases, and so color also becomes slightly reddish. We may have children with spasticity of cerebral palsy who have spasticity of the lower limb, not responding to the conventional treatment. So we got some role in doing obturator nerve block under USG guidance and or nerve stimulator, or combining both of them. These are the neurolytic blocks and usually done with alcohol and phenol. Moving down from spasticity to the cancer pain management, our MD students should be exposed to the management of cancer pain and the WHO analgesic ladder also about the mild, moderate, and severe pain. And they should be emphasized now that we should not go from 1 to 2 and 2 to 3. If pain is more, like pain score is 9 to 10, our students should be exposed to in the assessment of pain about the different pain scores occurring, like whether it is visual analog score or a numeric rating score, or the special scores for the pediatric patients. If pain score is 9 by 10, they can go straight away to the letter 3. Cancer pain, our aim is to assess the patient regularly, choose the appropriate analgesic and deliver it regularly, whether it is by mouth, by clock, and by ladder, and we have to titrate according to the individuals. If patient cannot take orally, we can give patches like buprenorphine patch or fentanyl patch, and if required, we can go for the nerve blocks. The most common intervention done for CA pancreas, CA gallbladder is celiac plexus block, done under fluoroscopic guidance, initially diagnostic, and then neurolytic block with 50% alcohol with the longer spinal needles, 22 gauge, 17 centimeter needle. And these are done under prone position. If you are planning USG guided or CT guided, then it is done under anterior approach with patient in supine position. And at times, for unresectable CA pancreas, we go for intraoperative celiac plexus block. If pain is in the lumbar region because of the carcinoma or metastasis, and it is causing regular component of pain, we can give an epidural analgesia and put an epidural catheter also. For CA breast pain, suprascapular nerve block provides 30 to 40% pain relief, repeated 2 to 3 times and given 6 to 7 sittings. For CA head and neck, glossopharyngeal region, and CA tonsil, glossopharyngeal nerve block provides good pain relief. It can be given by extraoral approach. Intraoral approach is not possible, and it can be given by extramedullary approach also. So principles of cancer pain management are to cure sometimes, to control often, but comfort always. And these, our MD students should also be exposed to the other advanced modalities of stimulation like dorsal column stimulation or deep brain stimulation. And these advanced neuromodulation pain therapy, they should know the basics and their mechanism of action, and about the spinal cord stimulator, how it is done, the lead placement, the single lead or the twice lead placed under fluoroscopic guidance, and also about implantable drug delivery pumps like intrathecal pumps, which are used for both neuropathic and nociceptive pain. These are implantable, externally programmable systems, which are put, the catheter is put in the intrathecal compartment. Our postgraduates should also know about principles of pain management in special patient groups, including elderly, children, disabled, like I talked about cerebral palsy, intellectually handicapped, and those who are unable to communicate. And they should also be able to practice pain management in patients with problems of drugs use, like drug dependency and drug addiction. And they should know and identify the parameters for referral to a pain medicine specialist. So they are students, but if they're not able to handle it, they should know that yes, there are anesthesiologists, who are senior to them, who are specially qualified, and refer them for particular management. And last but not the least, they should know about the basic principles of palliative care. To conclude, the solid foundation of appropriate chronic pain management relies on very detailed history, nice examination, relevant investigations and interventions. And it is a holistic approach. NMC had designed a curriculum. Now the onus is on us, the teachers, the associate professors, the assistant professors, and the professor and head of the departments to ensure that our MD students are appropriately taught and trained in chronic pain management. The curriculum is there, the list of blocks is there which has to be taught to them, some which have to observe, some which they have to assist, and some they have to perform. So I am very sure that with the intellectual brains across the country, chronic pain management will be taught very nicely at the postgraduate level. This is my pain team. All these pictures are not my alone, contributed by our pain team, which comprises of both boys and girls. Nothing has been taken from net, and these are our own pictures. I'm thankful to my parents and my teachers, because of whom I'm standing and sitting here and speaking on my favorite topic, chronic pain management. And today I am more happy because I'm talking from PG perspective. Thank you very much for a patient hearing. If there are any questions, they are most welcome. Thank you very much.
Malhotra. Next, we have discussion of 5 minutes. Over to chairpersons.
If I may be permitted, I wish to compliment all the faculties and especially Dr. Naveen Malhotra for enlightening on this part of the postgraduate training and teaching, which has been introduced very recently, I suppose, and may not be available to all the faculties all over the country. And I thank the organizers for arranging for this sort of a consortium of topics with day-to-day necessity for each and every practicing anesthesiologist, whether it be a postgraduate or a faculty member or a freelancing anesthesiologist. Back to the organizers.
Thank you, sir, for your kind words. Yes, I'd like to share with you that the curriculum has been designed. Now the onus is on us, as I've said, that in the medical colleges, we will have to recruit faculty or send them for training so that the faculty itself is trained, and then they can build up the pain team in the respective departments. And then the super specialty of pain medicine will be established across the country. Thank you, sir.
Absolutely.
We have got with us Dr. Anjali Bhure and Dr. Virender Sharma, treasurer of
Anjali Bhure has given us a smile at least.
And Dr. Nandita Mehta has joined us from Jammu.
Excellent.
I would just like to thank Dr. Morris and Dr. Karthik for a wonderful presentation, and especially Dr. Naveen for exhaustive coverage of the NMC curriculum. I mean, all the pain clinics and all the institutions and everywhere now we will have to rise up to a certain standard to have this kind of coverage so that our MD students are properly trained in pain. And definitely I think this branch, that is pain branch, is going to come up in time to come, because the recent curriculum stated by the NMC also is very exhaustive. Thank you so much, all the speakers.
One request I've already made to the logistics organizers to send at least to the chairpersons recordings of the 3 presentations that we had, because they have got an all-round effect, especially for the beginners. The first 2 topics for the beginners was very essential.
Very good.
Because I'm compelled to say that nowadays pre-anesthetic assessment is delegated to the junior most postgraduate in the institute, who may not be knowing, and they usually have their textbooks, which again discourages the patient who come to them for the checkup. So I think this would be a very good learning lecture that has been delivered earlier. And of course, Naveen's thing is for the faculty of the medical college.
Yeah. And Dr. Ashish has covered exhaustively, and it was excellent presentation even by Dr. Morris. Thank you so much.
See, Dr. Ashish has given those mnemonics, and I really appreciate the mnemonics
I have noted down. I have noted down those mnemonics.
Excellent.
Yeah.
I have
And
tried to note down, but I would prefer if we are sent the lectures, because those mnemonics will be very helpful for the postgraduates.
Yeah. And I still remember Dr. Naveen giving me one mnemonic of Suman K. And I always, whenever I want to teach class 3, class 4 employees, I always teach them Suman K. That is for hand washing
Hygiene.
protocol. And it is a hit in my college.
Excellent.
Yeah.
Naveen is fond of ladies' names, I knew, but I did not know about this.
No, sir. To be honest, this is for COVID and hygiene. And Suman is my mother's name, and K is
Excellent.
Kishanlal,
My respects.
my father's name. So it says Sida, Ulta,
Excellent.
Mutti, sir, Mutti, and Angutha, and Nakhun, and
So
Kalai.
that was very,
Excellent.
So this was about the hand hygiene for COVID pandemic, and I'm really thankful.
I would just like to ask one question before we part, that anyone has got experience regarding cervical epidural in thyroidectomy?
Yes, madam. In our institute, initially cervical epidural, cervical superficial and deep cervical plexus, and one of my very old teacher used to do it under even acupuncture also. So, but in very ESA grade 4 or 3, they have done it, and more for academic purposes, I can say that. But madam can throw more light on that. Now, during my MD, after my MD, I've only used general anesthesia only.
I may add here, during my visits to Africa and the Rotary Medical Mission, Nigeria, I have seen them doing huge thyroids under local anesthesia, under local infiltration, which was really inhuman. And they do it, and the patients do it because they have no other choice. These things have now possibly been shed, and now they have shifted over to general anesthesia during our period of stay of during the 3 periods.
Excuse me.
Patients are lucky person. Thank you so much. Thank you.
Thank you all. It was a wonderful.
Thank you so much.
Let Dr. Virendra Sharma say something.
Anything, Virendra?
Virendra sir is not saying anything.
No,
he is hiding himself.
Virendra is not open his mouth.
No, I was just listening. All the 3 talks varied. The second one was quite useful for the freelancers. The first one, that retro-external, that was for institute persons, because I think it should not be taken up by small places. And the third one, talked by Dr. Naveen, it's a new thing that it has been made compulsory. Although at my place during the NB examination, the examiner will always search for whether you have ultrasound or you have a pain OPD, you have the gadgets for pain or not. So it was very particular in the DNB setup, but now NMC has made it compulsory. So it's good that all budding anesthesiologists will be trained for this. At our time, such facilities were not there. So I congratulate all the 3 speakers.
Excellent.
Good work done by IS.
Excellent. God bless.
Thank you so much. Thank
Sorry
you.
to interrupt.
But just a final prayer.
To wind up.
Protect yourself. Play it safe.
Thank you, and same there.
Thank you.
Thank you.
Thank you.
We'll move to the next session.
Thank you to Dr. Venkatagiri for giving us this opportunity. Thank you so much.
Move to the next session. To chair the session, we have chairpersons